Hello and welcome to Bonus and Mind the Bleep webinar. This is our first one of a series of oncology webinars, and we're really excited to have you join us today. I'm Taylor and I'm one of the co-presidents of Bonus, and I'm joined with Miranda today from Mind the Bleep. And our two speakers tonight are Dr. Rachel Broadbent and Dr. Rohan Shotton from the Christie, and they will be talking to us all about cancer diagnosis. Thank you very much for joining us today. We're really excited to have you talk, and I'll pass over to you.
Thanks, Taylor, and thank you for the invitation to speak as well and for having us. So as with all these things, despite it being 3 years of online talks and so on, we're still just wrestling with trying to get Rachel into the room as a speaker. So we'll keep an eye on that, but we'll start chatting in the meantime. So we are both SPRs/fellows at the Christie and the University of Manchester. Rachel has just finished a really exciting PhD looking at lung cancer screening in survivors of Hodgkin lymphoma. I'm also working with the lymphoma team at the Christie, working on a PhD looking at new biomarkers of cardiotoxicity caused by anthracycline chemo. This is a completely different sort of sphere. This is the hardcore nitty-gritty of week-to-week MDT work in oncology, which is the bread and butter of what, as onco enthusiasts, hopefully what all of you will be doing in the future. So we'll start talking, and if Rachel manages to join us in the next couple of minutes, she can take over. So the whole point of this talk is to just go really from symptom to treatment in a little bit more detail than what we might all have seen as undergraduates or at early stages when we get to MDTs and so on. It was something that I didn't really appreciate as a med student, and then as an FY1 and an F2, by and large, far too busy to do things like MDTs in clinics. So we'll talk about the principles of working up a suspected cancer, some common presenting symptoms and signs. We'll work through one particular case that will hang most of the discussion for the hour or so on. Then we'll talk through the role of imaging specifically and pathology in each of those things. So we'll start talking presenting symptoms. Now, obviously, these are many and varied. Primary tumours can occur in just about any part of the body, as you know, and can cause any number of symptoms. Let's see what Rachel's just messaging me. Oh, sorry. No, look, sorry. So they can cause symptoms based on where an actual lump is growing, such as a breast cancer in the breast or lymphomas in nodes anywhere through the body. Some tumours, of course, are more prone to bleeding, such as those in the GI tract. And other tumours are prone to obstructing or compressing important things that don't want to be obstructed or compressed. The commonest of those are things like HPB cancers, which very commonly, of course, present with painless jaundice. And equally, the important point at the bottom there is blood vessels causing external compression. This is something we see absolutely all the time in patients with known cancer, but also new presentations of cancer, is DVT and PE. These are absolute staples of presentations with cancer. So if you're working in an acute medical setting and you see somebody who has an apparently unprovoked DVT or PE, you really need to be thinking carefully about whether this might be the first presentation of a malignancy. Primary tumours, as we've just said, can cause symptoms, but clearly so can metastases. Again, these vary enormously based on where they are in the body. Bone pain is a really common thing. It's unpleasant, but pretty opiate responsive in general. Pathological fracture is an enormous problem for our patients. It can happen with no trauma whatsoever, or it can be very low impact. And it's important that these patients are worked up by orthopedic colleagues with expertise in managing pathological fractures. Of course, we see patients with breathlessness or cough frequently due to chest tumours. And all of the others that you can see here, liver, brain, nodal symptoms. The important ones at the bottom, these non-specific systemic symptoms, constitutional symptoms of anorexia, fatigue, weight loss, nausea. Of course, a huge number of the population are fatigued anyway without having cancer. These are very common. And I might add to that list as well, B symptoms caused by lymphomas. We'll start talking about a particular case and see how far we get through before Rachel manages to join. This case will take us through most of the talk for the evening. It's a 74-year-old woman who turns up to see her doctor feeling breathless. On further pressing her, she has had about 4 weeks of feeling out of breath. She has dry cough, occasionally some dull central chest discomfort, and has lost a small amount of weight. She, as per most patients in their 70s, has osteoarthritis to some extent, high cholesterol, COPD and glaucoma. Medications as shown here. Importantly, she has a fairly heavy ex-smoking history, a light drinker of alcohol, lives with her husband, and she was fit and independent until 2 weeks ago. There's a family history of malignancy in her brothers and her mother, and that is what she presents to you. Systems review, I think, is a really important and underrated part of the history. Sorry to teach you to suck eggs if this is all basic for you, but it's very much underappreciated, and we all have to find our own way of tackling it. But in working up a patient with suspected malignancy, it's absolutely essential. So I think the key points are to look through all of the potential body systems that could be affected by the symptoms on the previous slides and tick them off mentally. So the salient points here are that this is a 4-week history, a relatively rapid acute history in that case, of breathlessness in a woman with COPD and a strong smoking history, who importantly again was fit and independent until 2 weeks ago. The key thing here is that she's gone from well to not well very, very quickly. When you examine her, she is in a wheelchair. Her performance status is 2. We'll return to that in a minute to explain what that means. Breathless at rest. She's hemodynamically about stable and has reduced breath sounds and a dull percussion note throughout the left side of her chest. Otherwise, the examination is pretty unremarkable. Otherwise, the features that we need to be looking for, of course, in the respiratory exam is evidence of infusions, infections, obstructions and peripheral stigmata of COPD. Cardiovascular exam is perhaps less essential. That's more about guiding your view of patient's fitness for treatment rather than primary cancer diagnosis. Abdominal features such as ascites, hepatomegaly, and as I said at the beginning, absolutely essential that you don't miss a DVT or PE. These are very, very common features. Of course, once we've got all of the clinical review, we then ask our healthcare assistants in clinic to provide us with bloods. These are just taken from a patient at the Christie that I saw a few weeks ago. On the left, the full blood count, and on the right, the so-called Christie profile, which is just a panel of U's and E's at the top, a bit of a bone profile, LFTs, and for historic reasons, an LDH, which gets done all the time as well. So important things that you might notice here is that this woman has a neutrophilia. She's hyponatremic, relatively good-going hyponatremia. You notice that her creatinine is fairly low. That suggests perhaps a low muscle mass, and certainly in proportion, her urea is very high. It's disproportionately high, isn't that urea, compared to her creatinine. So that might point towards GI bleeding or perhaps dehydration in the context of a woman who's actually of very slender muscle mass. The LFTs, of course, are important to always keep an eye on as well. When we're thinking about assessment of fitness, it's really useful to have a framework to hang our opinion on, and also to, track through a patient's journey from diagnosis and treatment, which can go on for many, many years. Some of our patients in lymphoma or breast clinics come with advanced, incurable cancer, but come to the clinics for more than a decade. So assessment of fitness is absolutely essential. This guides chemotherapy decisions, radiotherapy decisions, surgery, concurrent treatment such as chemoradiotherapy. Of course, rules exist to be broken, but as a general rule, chemotherapy would be very rarely offered when someone's performance status is 3 or 4. I should say that performance status runs from 0 to 5, 0 being completely fit and well and able to do all normal jobs and exercise, 5 being dead. So 3 and 4 at the shallow end of the performance status pool, you'd very rarely convince an oncologist to give you chemotherapy unless in a couple of very specific circumstances, such as a rapid decline caused by a potentially reversible malignancy like lymphoma or a germ cell tumour. So there are various ways of measuring performance status. This ECOG, Eastern Cooperative Oncology Group performance status, is the commonest. The Karnofsky performance score is more complex. That's a percentage from 0 to 100. Frailty score and comorbidity index, of course, are important as well. This is the most important of them all, though, the ECOG PS performance status. Hopefully most of us here are 0 to 1. The difference between 2 and 3 is an important one to delineate. The key thing here is whether you're up and about for greater than or less than 50% of waking hours. So if someone is resting more than half of the day, they are by definition performance status 3. If they are up and about more than half the day but not able to work, then they are performance status 2. A patient in bed or chair the entire day, entirely disabled or unable to look after him or herself, is performance status 4. As well as being useful for guiding us in treatment decisions, performance status also correlates pretty neatly with overall survival for many, if not all or most cancer types. This is a Kaplan-Meier plot showing the proportion of patients alive for performance status 0 to 4. And as you can see, performance status 4 in blue, perhaps 50% of patients there at 0.5 are dead by 4 or 5 months, which off the top of my head feels quite generous. Maybe it's 3 months, but it's bleak, certainly. So the bottom line of this woman's presentation, if you were to give a one-line summary to your professor in clinic after you've been to see her as a new referral, is that she is a previously fit 74-year-old presenting with rapidly progressing dyspnea, cough and weight loss in the context of a heavy smoking history. She is performance status 2 due to dyspnea with examination features suggestive of a left pleural effusion. She wanders off around the corner to the X-ray department and she comes back with images on PACS looking a little bit like this. The obvious finding, of course, being a whiteout on the left-hand side, which, taken with your examination features of a dull percussion note and absent breath sounds through the left, is strongly suggestive of a large pleural effusion there. You can see her mediastinum has been pushed away towards the right-hand side. There's also a small patch of consolidation on the right here. She goes on to have a CT scan. In this presentation mode, this isn't going to show us terribly well, but it's, I guess, just to make the point that a CT chest, abdomen to pelvis is pretty well mandatory in the vast majority of patients with suspected malignancy. There are a couple of exceptions to that, such as a very early stage, localized, small, low-risk breast cancer, such as an estrogen receptor positive, HER2 negative tumour in the breast. You might get away without a CT scan, but otherwise, you won't go far wrong if you assume that someone with cancer needs a CT chest to pelvis. Here's the bottom end of that CT scan showing the left-sided pleural effusion. So the radiology consultant opines that this patient has multiple lesions throughout the liver, probably metastatic from a primary lung neoplasm. No surprises there from the history of breathlessness and smoking history. There are multiple enlarged para-aortic lymph nodes, a moderate left pleural effusion causing some collapse, again, not uncommon. There is a subcarenal soft tissue mass density and a large left hilar mass with mediastinal extension, occluding the lobe bronchus of the left lower lobe, complete atelectasis of the left lower lobe, and a moderate to severe left-sided pleural effusion with atelectasis. And she suggests that this is put through the chest radiology meeting sensibly enough. At this point, we'll just pause the case discussion to talk through the role of imaging in cancer diagnosis. Imaging really is an essential part of our day-to-day work. There isn't a day that goes by in clinical work where we don't request multiple CT scans, X-rays, MRIs, and PET scans. Broadly speaking, we need to know, firstly, is the cancer causing a patient symptoms? For example, if a patient turns up to clinic with a long history of breast cancer but says that today she has backache, you need to know if it's cancer causing that or if it's just a long-standing musculoskeletal pathology. And secondly, is the cancer evident on examination or imaging or both? It tells you the extent of disease, therefore what stage is the cancer, therefore how to treat the cancer and what the treatment intent should be. On this point at the bottom, for the vast majority of cancers, sadly, again, there are exceptions, but the vast majority of cancers with advanced stage or metastatic disease, most will be incurable. That doesn't mean to say they have a short prognosis, because many patients, for example, with breast cancer, prostate cancer, some lymphomas, can live for years and years, in excess of a decade, with incurable cancer. So you will absolutely infuriate an oncologist if you, in general medical circles, for example, if our colleagues decide that somebody should be for ward-based care because they have advanced cancer when they might actually have a prognosis amounting to decades. So it's a really important thing not to assume that advanced cancer equals short prognosis. TNM staging, a lot of you will be familiar with, of course, referring to the stage of the tumour, regional lymph nodes and metastases. This varies hugely between different cancers, and there is, of course, no way that you can remember this. And I'm not aware of any consultant oncologist who knows the TNM system for anything but his or her own tumour site that he or she treats. As a general rule, though, the T status, the smaller the better. T4 typically indicates a large or locally invasive tumour. So, for example, here in lung cancer, a T4 tumour might be invading the mediastinum, the diaphragm, the recurrent laryngeal carina, trachea, esophagus. The nodal status typically goes for most cancers to N2. Lung is a little different and going up to N3. And finally, M status is either M0 or M1. Again, some cancers have an M1A, 1B, 1C. I think there's even an M1D in melanoma. But the key thing is basically a binary. Are there metastases or are there not? The number categories of staging you may also be familiar with. These go from 1 to 4 for pretty well all tumours. Again, there are very dense tables that you can read when you come to subspecialize in whichever particular cancer you're most interested in the future, which will translate, for example, a T to a N0, M0 tumour here tells us it's a stage 1B lung cancer in this case. The important thing here is on the right-hand side, if you've got an M1 tumour, so meaning metastases, that is by definition stage 4 in the vast majority of cancers. This describes limited stage small cell lung cancer. So stage 1 to 3 small cell lung cancer eligible for treatment of curative, used cautiously, intent. On the left-hand side here, for example, it suggests that stage 1 and 2, which is a tiny minority of patients with small cell lung cancer, can be treated with surgical resection, followed by adjuvant chemotherapy plus or minus chemoradiotherapy. Up to stage 3, you might consider in a fit patient concurrent or simultaneous concurrent chemoradiotherapy, or in a slightly less fit patient, chemotherapy followed by radiotherapy. So again, here, stage is absolutely vital, and you'll see that the difference between 2 and 3 leads to entirely different treatment pathways. Sadly, stage also correlates closely with 5-year overall survival. As an example here, this is, I think, from memory, for small cell lung cancer. And of course, outcomes, as you'll know, are pretty terrible with small cell lung cancer. There have been almost no been very, very little progress in palliative immunochemotherapy in recent years, and it remains a real challenge for us. There are, of course, different ways of imaging our patients. The commonest, the bread and butter of our day-to-day work, though, is the CT scan, which has now been around for several decades. It, of course, uses ionizing radiation to build cross-sectional images. it relies on tissues varying in density. So energy beams pass through some tissues more easily than others. It's quick and easy. It's cheap. A CT head without contrast might take a minute or two. A CT chest, abdomen, pelvis with contrast might take a little longer, but it's quick, it's cheap. Most patients will not feel claustrophobic in a CT scanner. It isn't so good for looking at tiny lesions in places like the brain or the liver. It's also a significant radiation dose and really should be avoided in pregnancy. And we also have to bear in mind, of course, patients with particular risk factors for future malignancies. IV contrast is a controversial thing. It says here that it can lead to renal failure. It depends who you listen to. More recent research suggests that it probably doesn't, but you don't want to be that person that puts a patient onto dialysis after giving contrast. MRI, of course, does not use ionizing radiation. It uses a huge magnet. The patient slides backwards on a bed into a much more claustrophobic tunnel. If you've ever had the misfortune to have an MRI scan yourself, then they're not the most pleasant of things. It, however, does characterize soft tissue much better than the CT. And if you look, for example, at some of the images of MR brains, it really is astounding, the detail that we can see. They're more expensive. They take longer. Some patients simply cannot tolerate them at all. And MR scanners clearly aren't compatible with some implants, foreign bodies. And there's a very long safety checklist that you'll have to go through before you can have an MRI scan. PET-CT combines two different scans. As the name suggests, you get a PET scan and you also get a low-dose CT scan. The idea here is to quantify the uptake of a radiopharmaceutical agent in combination with a CT scan. The radiopharmaceutical is fluorodeoxyglucose, so this is a radio-labeled glucose. This is preferentially taken up by cancer cells which are rapidly, have much higher metabolic activity than most non-malignant tissues, the brain and perhaps the myocardium excepted. That's given as an IV injection. The scan takes place around 60 minutes later, and the nuclear images are then overlaid on the CT scan to give a picture such as one of these. As I said, some tissues shine up on a PET scan entirely normally and physiologically, such as the brain, the heart. Here you can see the tracer being excreted through the kidneys and into the bladder. So that's entirely normal and reassuring. Clearly, this on the right-hand side, though, is highly suspicious of this patient with a highly FDG-avid mass in the right lung and a suspicious avid node in the mediastinum as well. I think Rachel's still struggling to join. We'll continue. So PET scans aren't used as frequently. They are more challenging for a radiologist to interpret for all of these reasons here. Some tissues shine up entirely normally. I mentioned the brain and myocardium. Down at the bottom, important to remember in our young patients, such as those coming through a teenage young adult lymphoma clinic, that patients with lots of brown fat will have high FDG uptake in other places as well. Clearly, a PET scanner can't tell the difference between infection or abscess and inflammation and malignancy. They all appear much the same. You'll be asked to stop metformin temporarily before a PET scan because it causes pretty spectacular bowel uptake. And some other things like granulomatous disease and fat necrosis can also cause false positives and therefore anxiety for patients. So why might we use a PET scan? Well, firstly, it gives us a pretty good idea if a mass seen on a CT scan is malignant. Clearly, if it's an abscess, it might also be avid, and some malignancies might not be FDG avid, but it's useful. It can guide response assessment in some cancers, and importantly, it's a whole body scan. It really does go from the vertex of your skull right down to the bottom of your feet. And so in a peripheral cancer such as a sarcoma, it can be really useful for telling us if we've got disease elsewhere in the body that a CT chest to pelvis wouldn't show. A radionuclide bone scan is used occasionally in some clinics to look specifically for bone metastases. Again, this uses a radionuclide agent, here technetium-99, and this is useful for detecting and monitoring bone mets, usually picked up earlier than on a than on an X-ray. So that's imaging in a nutshell. The headline news, though, is that a CT scan really is the bread and butter and is pretty mandatory. MRI scan if you're wanting to look at soft tissue in awkward places like the liver or the brain. A PET scan if you're wanting to look at some specific tumour types, lung cancer, lymphoma to name a couple, melanoma. And otherwise, your radiology colleagues will always be more than happy to guide you in which scan to request and are always delighted when their opinions are asked. That takes us neatly to lab investigations in suspected cancer. As you'll know from ticking request forms at work, or as you will come to know, there are, of course, millions of tests available on just about every substance that the body can produce. These can be used to aid diagnosis, to assess fitness, and, of course, to plan treatment. Going back to our patient at the beginning, she had a good-going leukocytosis because of a neutrophilia. In her case, that could be just a reactive picture because of her developing what's almost certainly a lung cancer. It could equally be caused by steroids if someone has sensibly enough given her a course of steroids to help her symptoms. And the hyponatremia, again, really is pretty common in patients with some types of lung cancer. Important to say, though, that these bread and butter blood tests will very, very rarely confirm a cancer diagnosis. They may point you towards certain cancers, but a full blood count and set of biochemistry, as a rule, won't tell you what cancer a patient has. We commonly see anemia. The vast majority of our patients with advanced cancer have subnormal hemoglobin. As I mentioned about leukocytosis a moment ago, lots of patients similarly can have a thrombocytosis due to inflammatory states. Liver enzymes, of course, can be deranged in obstructive or hepatic patterns, and hyperbilirubinemia can follow either of those. Hypercalcemia is a common presenting feature of cancers and really does imply either bone metastases or a paraneoplastic phenomenon. The LDH is an interesting one. It's done to a crazy degree at our hospital at the Christie, where every biochemistry panel will come with an LDH. In other hospitals, it's done very, very rarely. It's a pretty crude marker of high cell turnover. So as a very hazy idea of treatment response, it can be very useful, but it's not the greatest test by any means. And some paraneoplastic conditions can cause hyponatremia or calcemia, as I said. Tumour markers are perhaps more interesting, but they're also a bit of a dark art, and we all have to resist the temptation to be too taken with just requesting a panel of tumour markers for everybody with a lump where there shouldn't be a lump. And there is fairly specific guidance for GPs and secondary care clinicians on which tumour markers to request and when. The reason for the caution and hesitancy with tumour markers is the right-hand column in red here, which is that there is a significant risk of false positives and false negatives. So in red here, all these conditions can cause false positive tumour marker rises. And equally, not all patients, for example, with colorectal cancer will have a raised CEA. To go through these very briefly, though, the most important ones that you'll come across in undergrad exams, finals, or MRCP will be things like the alpha-fetoprotein in some germ cell tumours and hepatocellular cancer. However, of course, also we have to be aware the patient with cirrhosis, pregnancy, and some other cancers. Calcitonin from medullary thyroid cancer. CA15-3 is secreted in a small proportion of patients with advanced breast cancer and has a pretty limited use in diagnosing breast cancer, to almost no use, but is useful in monitoring treatment response in a known secretor. So there's no point going on and on requesting it in a patient with advanced breast cancer if she's never had a raised 15-3. But if it was raised from the outset, then it's useful to follow it on serial testing. CA19-9, much the same applies, but for pancreatic or biliary tract cancers. CA125 with ovarian cancers, the CEA in colorectal cancer, HCG in some germ cell tumours and gestational trophoblastic disease, and of course PSA in prostate cancer. Of all of those on the table, PSA is probably the most useful and the widely used. Again, though, it's important that we're all aware that PSA is not specific for prostate cancer, and there are any number of things which will put your PSA up and cause a huge amount of anxiety and worry for a patient. So take-home message there is to be careful with and be cautious. Don't just tick all the boxes, because you'll end up with a panel of results that you really can't explain and a scared patient. We'll move on to talk about pathology in cancer diagnosis. Our histopathology colleagues are really the absolute salt of the hospital. We couldn't work without them. They do a heroic job behind the scenes. They are very much the unseen heroes of the whole process of diagnosis. Going back to our 74-year-old with breathlessness, weight loss, and a mass in the lung and in the liver, the pathologist is sent a sample described as this. So this is pleural fluid cytology from a pleural tap or a chest drain. So the history given is a metastatic lung cancer, query small cell, query lung cancer, urgent please. The pathologist says, well, it's 40 millilitres of cloudy red fluid, and then goes on to say it's a sample containing cohesive groups of malignant cells. They have an increased nuclear to cytoplasmic ratio, loaded nuclei with salt and pepper chromatin, clearly a malignant sample. Morphologically, meaning purely on basic H&E stains, it looks like it may be a small cell carcinoma, but immunohistochemistry will be done and a further report will follow. So that kind of cytology or histology report you'll see very commonly, and we'll talk through what that all means shortly. Shortly afterwards, a supplementary report comes back with the results of the immunohistochemistry. Neoplastic cells are positive for CD56 and synaptophysin, with punctate positivity for CAM52. TTF1 is negative, Ki67 80 to 90%. The immunoprofile confirms the diagnosis of small cell lung cancer. So it's beautifully wrapped up in a package for you. So we'll talk through what each of those bits mean. This was something that I really did not appreciate to any extent at all as a med student, as an FY trainee, or as a core medical trainee. And it's only in more recent years as an oncology SPR that I've read more pathology reports in detail, been to MDTs and got friendly with some pathologists. Pathologists on that point are a very friendly bunch and will almost always invite you into their office for cake and microscopy if you happen to be lacking friends, as some of us are. This is an H&E stain, hematoxylin and eosin stain of a patient with small cell lung cancer. So this is the bread and butter of morphology. The process of selecting a biopsy site, however, needs to be taken into account based on a few factors shown here. So the commonest way to approach this is based on the history, the exam, and the imaging, and then to select a biopsy site based on, well, what is easy and safe to access, what's the most clinically concerning lesion, and what does the patient want. So clearly a large lump in the neck is pretty easy to get to with an ultrasound probe and a big fat needle, compared to a tiny lung nodule the size of a pea right in the middle of the chest, which is dangerous and unpleasant to get to. Which is the most concerning lesion is a slightly different thing. So, for example, if you've got a patient with suspected bowel cancer, but also a suspicious lump in the liver, well, clearly in that case, yes, you could get tissue from the colon via a colonoscopy. But if this is a liver metastasis, that completely changes your treatment intent from curative to palliative, probably, and changes how you're going to treat the patient. So in that case, you may well want to go after the liver lesion first. Some patients may simply not be fit for certain biopsies or procedures, or may not be all that enthusiastic to undergo them. There's a subtle difference between histology and cytology. Histology refers to a solid sample, a needle biopsy, ideally a core needle biopsy, or an excisional biopsy, even better. This can be done via a needle externally by a radiologist, for example. It can be done via endoscopy or laparoscopy, thoracoscopy, or perhaps in a more dramatic situation as a laparotomy. So sometimes, for example, if a patient goes for a laparotomy for their bowel cancer or their pelvic malignancy, then very frequently suspicious lesions on the liver might be quickly excised, biopsied, and sent off to the lab. Cytology, on the other hand, refers to diagnosis from fluids: urine, sputum, CSF, pleural fluid, pericardium, others. This is usually a fine needle aspirate of any of those places, or brushing, such as from the biliary tree in an ERCP. As a general rule, if you can get histology, a solid lump of cancer, you'll have a much happier pathologist than cytology. It's far harder to diagnose cancer confidently from a few cells sloshing around in a litre or two of pleural fluid compared to a solid lump of lung cancer. Who gets the tissue? Well, commonly a physician, such as a gastroenterologist or a respiratory physician, a surgeon or a gynecologist, or a radiologist using an ultrasound probe or a CT-guided biopsy. Here's an example of a patient undergoing a kidney biopsy, probably by a radiologist. The ultrasound transducer is held in close proximity and then under close monitoring to make sure that the needle's going into the area of concern within the kidney. Some cores will be taken via a coaxial needle looking something like this. In breast cancer, you probably will have come across the term sentinel lymph node biopsy. This refers to a radioactive substance or dye being injected directly or adjacent to a tumour, and then a couple of hours later in theatre, looking at the lymph nodes within the axilla and excising the sentinel lymph nodes for staging purposes. The principle here being that the sentinel lymph node, or the first lymph node, acts, if you will, like a gatekeeper, and you can fairly confidently say that if a sentinel lymph node is negative from a breast lump, meaning if the first lymph node is negative, there probably aren't involved lymph nodes downstream of that. So you can probably spare that patient an unpleasant full axillary node clearance. Here's a CT-guided lung biopsy being done. So the patient will be carefully positioned in the scanner, will be marked up on the skin, usually with some felt tip pens. They'll go in and out of the scanner whilst the radiologist wears lead aprons and ducks behind the lead screen for the protection of their own safety. And very slowly and carefully, the needle will be advanced into the tumour. And then they'll usually do a post-biopsy check to make sure that, for example, they haven't popped a pneumothorax. So the radiologist does her procedure and copies and pastes the clinical history from the request card for the CT-guided biopsy onto the histology request form. And the question then is, well, where does it go? It magically turns up in the lab, of course. And once it gets to the lab, they'll do various things to it. It will be very finely sliced and then undergo a number of stains. These are just some common stains used in Hodgkin lymphoma. And again, just as with staging, you wouldn't be expected to know the minutiae of staging for multiple tumours. You similarly wouldn't be expected to know the immunohistochemistry profile of different tumours, but it's interesting and worthwhile having a vague idea. So here's an H&E slide first in the top left. This shows the classic owl eyes appearance. I hope you can see that, this big lump in the middle. So Hodgkin lymphoma Reed-Sternberg cells, as you may remember, characteristically have this owl eye appearance. Then you'll notice that on these subsequent IHC stains, that particular Reed-Sternberg cell in the middle has taken up the CD15 and CD30 markers, but not the others. So that profile there is very much in keeping with a Hodgkin lymphoma. Other tests available, well, it's an ever-expanding field. FISH, fluorescence in situ hybridization, is useful for chromosomal analysis. So if you're trying to subtype a particular cancer, so here, as an example, a mantle cell lymphoma characteristically has the T1114Q13Q32 snappily named translocation, which is a hallmark of mantle cell lymphoma. FISH in that case is going to be a clincher of a diagnosis. And molecular tests, which we'll talk about in the next couple of slides, are again really useful in some selected cancers for guiding treatments. So some common examples here, for example, estrogen receptor, HER2, ALK and ROS1, EGFR, PDL1, that should be rather than PDL exclamation mark. Even oncologists get excited sometimes. BRAF and many, many more. So here's an example going back to colorectal cancer. So here's a patient who's got a liver fairly sadly chock full of suspicious lumps that look very much like metastases on both sides of the liver. So we consider, well, what will change management and what's the safest to access? The patient has the biopsy. It goes off to the path lab for immunohistochemistry with conventional stains. The pathologist then says, well, actually, this looks like a colorectal cancer, and I know that we can now do these additional statuses. So why don't we request a few further tests that are particular to that particular cancer? So here, colorectal cancer. If it was a lung cancer, though, there would be different particular tests. And again, PCR then is useful for some further testing, again, really to get down to the nitty gritty. The purpose of this is to really do a deep dive into, well, yes, this may be lung cancer, but what flavour of lung cancer it is. You know, lung cancer is a catch-all term for a tumour in the lungs. It doesn't tell you anything about how you're going to treat it, how long the patient will live, whether they'll live or whether they'll die. And so we absolutely must, it's absolutely mandatory that these specific further tests are done on pathology sample for whichever cancer it may be. There will be particular tests that you need to do. To run with the colorectal example for a minute, here's the CT scan again. Here's some immunohistochemistry staining on the top right that I've just purloined from the internet. So you'll see it's pretty small, but you'll see CEA, carcinoembryonic antigen, the same as the tumour marker, but also done on a pathology specimen is useful. And then the key ones here will be CK7 and 20 will give a characteristic pattern. So IHC is absolutely vital. Then looking at molecular testing, well, we want to know in colorectal cancer what the RAS status is. RAS is a gene, an oncogene that codes for particular proteins which will guide us in choice of treatment for patients with colorectal cancer. So it's really vital that we know their RAS status, whether they have a mutation or whether they are wild type. We also want to know whether there is a BRAF mutation in colorectal cancer these days. That's a fairly recent innovation as of about 5 years ago. The HER2 status is also applicable to colorectal cancer. You'll know it from breast cancer, but about 5% or so of patients with colorectal cancer will be HER2 positive, and NTRK fusion in a small number of cancers as well. So again, these can be mutually exclusive. So generally, a BRAF mutated tumour will almost never be also RAS mutated. They tend to be exclusive. There's only a tiny crossover between the two, as an example. But it's important that the take-home message here is that it's really important that for whichever particular cancer you're looking at in a given case, that you have a careful idea of, well, exactly what flavour of bowel cancer is it? What kind of lung cancer is it? Once we've got all of that information back from the pathologist, that will usually be a fairly lengthy report for most cancers that for some will amount to several sides of A4 paper. For others, it'll just be a short paragraph or two. Of course, the case needs to go through an MDT. This is, again, non-negotiable. This must happen for all new cases of cancer nationally. And it typically happens once a week. It can take anything from 1 hour to half a day or longer. And some of the grimmer MDTs I've had the misfortune to sit through will generally list all new cancer diagnoses and any particularly challenging cases for which we'd like a radiology or pathology review, or just some second, third, fourth or fifth opinions from colleagues in the room. Typically attended by consultant physicians, surgeons, a radiologist and pathologist, some senior nurses who know the patients well and actually often chip in with some of the most important things in MDT, such as, oh, well, you know, Mr. Jones is currently nursing his wife through the last stages of dementia, and will very unlikely want any investigations for the suspected cancer. That's clearly essential. Us lot as oncology trainees or surgical trainees will usually turn up in MDT as well and sit at the back. There'll be an MDT coordinator who writes minutes and keeps everybody on track with the correct notes. There'll be a brief discussion of each case led by the chair. The decision-making process needs to be really carefully documented. It's always a headache in clinic. On the rare occasion that you get a poor documentation from the MDT, it's an absolute headache if then 2 weeks later you're trying to think back and say, well, why did we recommend this treatment? And you're trying to explain that to a patient. So clear documentation is important. Say at the bottom that it must always be professional, though clearly discussions can get very robust or even heated. And sadly, I'm sure you will all see pretty ugly scenes in MDTs at some stage in your career where it turns unpleasant. Happily, without exception, every time I've seen that in an MDT in the past, it hasn't been because of particular egos, but rather because everyone wants to do the best for a patient and they're having a sporting disagreement and they all kiss and make up afterwards, usually. But we just have to be a little bit thick-skinned in MDTs. So this woman, going back to the kind of the index case, this 74-year-old woman with a 4-week history of dyspnea and cough and a history of COPD. We know she was independent 2 weeks ago, but is now severely dyspneic and wheelchair-bound. The radiologist pipes up that she has a large left hilar mass causing obstruction of the left lower lobe bronchus. There is a large left-sided pleural effusion, multiple liver mets, and this is clearly stage 4 disease. The pathologist confirms that the pleural cytology is in keeping with small cell lung cancer. And in this case, it's a fairly clear open and shut case that this needs a referral to a medical oncologist for palliative chemotherapy. If it hadn't been stage 4 disease and perhaps hadn't been small cell, if it had been a stage 1 lung adenocarcinoma or squamous cell carcinoma, then it might have been a referral to a cardiothoracic surgeon for consideration of surgery. Sadly, in this case, though, this patient needs to come and see a medical oncologist. That takes me to the end of a really whistle-stop tour from presenting symptoms to diagnosis. We've spoken about a huge amount. I'd be really interested in any questions or comments you might have. This whole process is an art rather than a science. And I guess the important thing that we haven't touched on at all is the human aspect of it, in the sense that at the heart of all of this process is a terrified patient who, during this period, which might take anything from 1 to 6 weeks to do that whole process, that patient will be thinking about whether they have to say their goodbyes to their loved ones, sell their house. It's a terrifying time, and it really is non-negotiable that they're supported through that period by a good clinical nurse specialist. So with that point, thoughts on a postcard? Any questions? I'd be really happy to take.
Thank you very much for the talk. It was really, really great. It was really interesting. And our apologies for not getting Rachel to be able to join. We still haven't got to the bottom of it, but we'll work out in the future and sort that out for the future. But thank you very much, Rohan. It was a really great talk. I've just got one question. Anyone else, any questions, feel free to pop them on the chat and I can go through them. But I've just got one question quickly, more about your career path, really. So what drove you into oncology, and how did you get there? What's path you took?
Yeah, absolutely. Well, the first thing to say is that I absolutely love my job. I'm doing a PhD at the moment, and that's very different. But when doing normal day-to-day medical oncology SPRing, the vast majority of the time I absolutely love it. Clearly, we all have bad days, but I wouldn't do any other job in the world. And I would happily talk to all of you for hours and try and convert you to come and be medical or clinical oncologists, because I think it's a fantastic career. In my case, I suddenly kind of thought, as a fourth-year medical student, I was sitting on a bus and thought, hang on a minute, I want to be an oncologist, and didn't change my mind after that. So I picked out placements from there on where I'd get lots of exposure to oncology. I made sure that in my non-oncology placements, I was sort of looking out for patients with cancer. For example, when I did elderly medicine, you can usually find an audit or something to do on elderly people with cancer. or in surgery. I made sure that I got to MDTs and made friends in clinics and so on with some oncologists and found some good mentors. When I then I chose a foundation program that had a job at the Christie, in which I absolutely loved. I was lucky that my first supervisor as an FY2 was fantastically inspiring, and I still work closely with that professor now. Then again, I chose a core medical training path that had an oncology job elsewhere in the country, which I enjoyed, and I wouldn't want to do anything else. So the pathway now, if you're interested, is to do your FY1 and F2, then to go and do 2 years of internal medicine training rather than 3 as it stands. So if you want to be a cardiologist or a gastroenterologist, you do 3 years, but for oncology, you can duck out after 2 as it stands. That may change. You then apply to be an oncology SPR, either a clinical oncologist or a medical oncologist. If anyone doesn't know, the difference for that is simply that clinical oncologists deliver radiotherapy as well as systemic therapies, chemotherapy, whereas medical oncologists, we are much more narrow-minded and only deal in systemic therapies. So that you then apply for an ST3 job. As of a couple of years ago, there is now a common ST3 year shared between ClinOnc and MedOnc. So regardless of which one you have been allocated by the interviews and selection process, you do the same sort of year. You do some basics of chemo and radiotherapy in common tumour sites like breast, lung and colon. And then after that, you diverge and we do slightly different exams. MedOnc training is 4 years as an SPR. A majority tend to do PhDs or higher degrees as well, but not everyone. It isn't mandatory by any means. Clinical oncology is 5 years of training. Still plenty do higher degrees, perhaps not not quite as many though.
That's great. Thank you very much. It's really interesting to hear about your career path. I don't think there's any questions in the chat at the moment, but I'm sure if anyone's got any, I'm sure you wouldn't mind them emailing you.
Not at all. Really happy to. Please do pass on my email address if anyone wants advice about careers or applications, these kinds of things. We're really happy to help. I can't recommend it enough as a career. Really fantastic mix for me of clinical medicine, so good medicine, good signs and good pathology, research, and kind of the human aspect of really developing good relationships with our patients. I promise you it is not as depressing as you think, and we give a lot of really good news as well as bad news.
Of course. Well, thank you very much. Thank you for a great talk, and we'll have to see you at future events.
Not at all. Thanks very much. Bye for now.
Thanks, everyone. Thanks for attending. Thank you.